Should we start?
Yeah, I guess we can start, and if people still join, then they can join in the middle.
Alrighty, so our topic today is dental examination of patients and X-ray. We are Moritz and Julie, third year and second year. We're going to present about dental examination, DMFT and DMFS index and X-rays. And our content is going to be, as I already mentioned. So, first topic is examination paper. I actually chose this paper that we're using in Svarte Ani also. So you start with the 8+, which is the 1/8 tooth, and then you go from one tooth to the next one until -8, which is 3/8, so the third quadrant. And just always make sure that you have the correct patient in front of you with the correct paper. And I mean, there's many different kind of papers that dentists are using. So this is just one example that we're using in Svarte Ani. And in case you were wondering what stavgroepo means, it means the condition of the tooth, and nadere osteotomy means the treatment plan. So in the first line, you would basically put what you see in front of your, like in the patient's mouth. Nowadays, clinics are often using digital software programs. So I just put a picture of iSmile. So you can see everything can be directly put into the computer, and even treatment plans and also costs and so on can be viewed in there. So it's all connected to each other, and it's quite cool. So the symbols that we're using in our practice here in clinics are the following. They're quite helpful because it's much easier to write the symbol into the examination paper than if you had to write always filling or caries. So it's really useful to know them. Some of them are from the Czech language, like dental calculus, ZK, zubní kámen, or filling P for plomba. So they will obviously be different if you're going to practice in a different country.
And just want to say, not only good to know them, but actually required in most oral exams in dentistry. Like, it came a bit of a surprise to me for a restorative exam in last semester. She all of a sudden showed me some symbols and asked me what they meant. So always know them before the exam too.
So now DMFT and DMFS index. DMFT means decayed missing filled teeth, DMFS decayed missing filled surfaces. Both of those indexes are used for over 70 years now. The instruments that are used are basically just a probe, mirror, and the cotton roll. The cotton roll is actually really helpful in combination with the air dryer to make the saliva go away, because it can be quite hard to see composite, and it's easier if you see if it's everything dried and it's more matte and less glossy. And as I already mentioned, you start with the number 1/8 and then you go from quadrant to quadrant, tooth by tooth. And also you should do an X-ray afterwards, because it's not possible sometimes to see the interproximal caries, and that can be added to the DMFT or DMFS index afterwards. The DMFT procedure is basically you just go from one tooth to another, and you basically just write how many teeth are decayed, filled, or missing. And it depends how many teeth the patient has. So 32 if the third molars are present, 28 if no third molars are present. And you can always just count one, like each tooth can only be counted once. So even if one tooth has a filling and is decayed, it will be just counted for the decayed one. So you always just count the 2 decayed teeth, for example, the 3 filled teeth, and the 1 missing tooth, and in total you get a DMFT of 6. And then when you want to do the DMFS procedure, you're going to write it into this chart, for example, to see where exactly on which surface the decayed, missing, or filled tooth is. So you can see that the molars and the premolars are always having 5 surfaces, and the canines and incisors are only counted with 4 surfaces because the occlusal surface is kind of small. So in this case, you would just write into this chart where you can see for example, the caries, and then it's like great to see where exactly the caries is. And you're going to have a total surface of 128. Then the grading for the DMFS is from 0 to 7. If the tooth is completely healthy, we will put a 0 into the chart. If it has, for example, greater defect than 2 millimeters, a 4. For the filling, a number 5. For missing teeth, a 6. And for the non-erupted teeth, a 7. So that can be just put here into the chart. For example, if this has a big caries lesion, you'll put a 4 in here, and then you will know. And then, yeah, you just count all the surfaces that are decayed, filled, or missing, and then you receive the total of DMFS. The advantages of these indices is that they can be used for permanent dentition as well as primary. For the primary one, you're just going to use small letters. And then if you have mixed dentition, you can make a DMFT in capital letters and a DMFT in small letters, and you will have them separately. Then it's quite quick and easy to use and to perform in the patient to see like an overview of the patient situation when it's, for example, also a new patient. Then it's international and uniform, so everyone uses the same procedure and the same letters or the same like numbers. And this is good for epidemiological evaluations, like you can, for example, see in this chart, because you can see how developed countries have decreased their DMFT from almost 5 to nowadays around 1. So yeah, because every country is using the same index, you can gather those informations together. Disadvantages are that the index doesn't indicate the number of teeth that are actually at risk of caries, and also it doesn't distinguish between decayed, missing, or filled teeth. So the number won't be worse if, for example, the person has a lot of decayed teeth. It will be the same one as if the patient had a lot of filled teeth. And then also it can only count 1 tooth or 1 surface. So even if it has caries plus filled tooth, you will only count the surface once. And then also the index is irreversible. So you can get a lower index even though when you improve your oral hygiene, because if you have a filled tooth, it will always be a filled tooth. So you can't use it as a motivation factor for patients to improve their oral hygiene. And yeah, Moritz can take over now.
Yeah, thank you. So now I'm just going to talk a little bit about the very basic practice of clinical examination, how it's expected of you in Svatani. Of course, it's a very vast field, like clinical examination. You can basically find anything in the mouth, and there are like so many, of course, except visual examination, there are so many additional examinations you can do. X-ray, the most common one, but also there's different things with lasers and electrical and on different based on different physical properties. But here I'm just going to go on the typical clinical preventive examination that you will do when you get a patient in Svatani. That's basically your day-to-day examination you're going to do. So next slide. Julie, can you switch the slide? Thanks. Okay, just a very small introduction, like summary. So first, of course, you introduce yourself to the patient, ask them to sit down. preferably in check. So before you, like second years or even first years, like before you get your first proper patients in third year, make sure you know at least the basic commands in check for the patient, so it's a little bit less awkward. Adapt the dental chair, make it as comfortable as possible for the patient. Explain what you're going to do, and then first thing to do is take the patient's history. It's always easy to forget. You always want to jump right into the mouth and start examining, but of course the patient's history is the most important, or a very important component of the clinical examination. Then you'll get the overview of the oral situation, going tooth by tooth, and also the soft tissues in the mouth. And you can make use of different indexes like DMFT, DMFS, and also different parodontological indexes. And in the end, you can do X-rays, and from this examination, create a treatment plan and possibilities for the patient that you can discuss with the patient. Next one. Okay, so first thing you do when you see the patient is not, of course, after a while you ask them to open the mouth and you talk to them, but as soon as they enter the office, you should have a good look at the patient. I know, especially as a student, it's like always a bit, you don't really see the patient as a patient, you just want to get right into the mouth and see the teeth, but have a good look at the patient itself. There are sometimes some things you can already see from extra-oral examination, like the general appearance, the skin tone, if there is any asymmetry in the face, any swellings that can be caused by dental trauma, for example, or dental abscesses or inflammation in the mouth. Sinus tract, like you see in the upper picture here. Yeah, or like stuff with the lymph nodes, swollen lymph nodes. Palpation of the face is very good there. I mean, I'm not saying you should, in every preventive clinical examination, you should start palpating the face. That's not commonly done, at least not in the hospital here. But if the patient complains about something, some swelling or so, then of course it's often good to palpate, as it's like not always like clearly visible to see swellings or other pathological situations. You should also check the degree of mouth opening. If they have some troubles with the temporomandibular joint, or with the muscles, sometimes they can't open the mouth fully, or they have some pain when opening in the mouth, and then you can also examine the temporomandibular joint by palpation mainly. Next slide. And then, like I said before, very important and often forgotten by students is the medical, dental history, often maybe ignored by students because you have to do it in check, and it's a little bit more advanced than to say Otto-Frete-Huster. So, of course, in a proper dental office, you should take care of the whole medical and dental history, meaning all like properties, big diseases they have, traumas, pain history, previous treatments, whether it be restorative, periodontal, endodontic, basically anything to do with the oral cavity. You should ask them for allergies, for medications. Of course, you should ask them what their chief complaint is, why they came to the office. Maybe they just came for a checkup, but if they have pain, you have to ask them where the pain is and what type of pain, and yeah, everything that has to do with that. Anyways, like if you're gonna get your first patients and you're gonna do the examination, at least ask them for diseases, allergies, and medications, and write this down in the examination paper. There's like in check a little box for diseases, allergies, and medications. And even if the patient already has been there, and the box is already filled out, you still have to ask them again and check if something changes. Maybe they discovered some new allergies or take some new medications. So always ask those 3 questions at least. Next slide. And then it gets to the main part, the intraoral examination, which involves, of course, the hard dental tissues, which are the teeth and bones, and the soft tissues in the oral cavity. Here I would really recommend to develop a consistent system of the examination for yourself. Like, I guess there are different approaches. Every doctor does it different. Like, whether you start with the soft tissue, or you start with the teeth, or you start with the buccal surfaces, or you start with the palatal surfaces. It's up to you, but try to have a consistent system so you repeat the same thing in the same way of examining with each patient. This way you'll never forget anything. You will never forget one surface or one tooth or something like this. like Julie said before, in Svarte Anni, you'll have this specific examination paper where it starts at 1.8 and ends at 3.8. So you have to first start with the number 8 of the first quadrant, then go all the way around to number 8 of the second quadrant, and then start with number 8 of the fourth quadrant and go all the way around to number 8 of the third quadrant. So try to not to get this mixed up. For example, go from second to third, then the nurse will put it wrongly into the examination paper. Also, when reading out the status, don't just say, keep in mind the nurse doesn't see what you see. They might stand next to you, but they don't always have the perfect view of the oral cavity. So always say which tooth you're on. I always just say the number. I say, okay, I start with first quadrant and then say number 8, not erupted, number 7, filling, number 6, caries, and so on and so on. And always say the tooth. Even if there's nothing, then I just say, okay, number 6 is healthy, and that's it. And yeah, the nurse also, and you also should keep an eye on the old status records in the patient like examination paper, what has been filled in like maybe half a year ago, because it can help you a little bit to find those things again. For example, it happened a few times to me that I like thought a tooth is healthy, and then my nurse or my classmate told me, oh, but there's actually a filling. And then I had to look again and thought, oh, yeah, actually, there's a composite filling I didn't see. So always have a look at the old status record and then kind of just look for what changed. And this way is like a good way not to forget anything. Next slide. Yeah, and then to basically probably the main part of the clinical examination is the examination of the teeth. Some basic principles are like really put the patient in a position that's like good for you, that's comfortable for you, that you can see everywhere comfortably and you don't have to like bend over or stand on one leg or anything. Move the chair and move the patient's head in a way that you have a good view of the oral cavity. Use good illumination, obviously. Use a mirror and a probe. The mirror you can use also to shine light onto specific areas. You can use it to examine surfaces of the teeth that otherwise you wouldn't see. The probe is mainly to test if something is, for example, just a discoloration or if it's a cavity, to test for hardness of the structures, and also to test fillings and the margins. Always use a dry field to examine the teeth. You use the air and you can help yourself with cotton rolls or the suction if there's like a lot of saliva. Otherwise, you won't be able to see often the demineralization of the teeth or the white spot lesions or caries if you don't have a dry tooth. Also, if there's an excessive amount of plaque and food rabies, either ask the patient to brush the teeth before coming, or if they don't do this, then give the tooth a quick cleaning with water or even with a small brush so you can perform a proper examination. And then, like I said, you start with 1.8 and just go tooth by tooth, surface by surface. And first thing you should always like tell the nurse is what like state is the tooth in. Is it a normal tooth with the original like tooth substance, hard dental tissues, or is it extracted or unerupted? Which one, extracted or unerupted, is sometimes hard to see. So you can always look in the patient's history if the wisdom tooth, for example, just didn't erupt, or if it was unerupted, or you can check the X-rays of the patient. Then you should, of course, say if there's some prosthetics work, like a crown or bridge or etc., like stuff like this, root canal inlay. Next slide. Okay, so now some general things to find, like on a tooth, if you have one to examine. Of course, there are many, many things to find, but I'm just gonna go over the most common things that you'll probably see each week when you have a patient. First is prosthetic work. You can see crowns, bridges, pontics, implants, root canal inlays, all kinds of things. You all learned it in prosthetics course. You should always, first of all, note down that there is whatever there is in the examination paper, and then you should check the quality of the prosthetic work. If it's still holding onto the tooth properly, it's not movable, or it's not broken. Especially in facet crowns, often there's like the broken ceramic on the metal and the metal is blank. It can happen that in the frontal teeth areas or even in the molars, if there's like a really thin crown, that there are holes developing from attrition, from the chewing. And you should check if the margins of the crown are well well sealed, so there's no chance of secondary caries. On the picture here, you can see the like really bad crowns or bridge radius, I think, like where the margins are kind of open and it's not really well sealed, and you can see there's probably a secondary caries gonna develop pretty soon. For this, you can always use the probe, like go with the probe along the margins, see if you can kind of like if there's a gap or if it's smooth. You should check if it's actually a real tooth under this crown or if it's an implant. And yeah, basically, according to this, in the end, you can decide in your treatment plan if you're gonna renew the crown or the bridge, or if you still like leave it in for a few years or until something changes. Okay, next slide. Okay, so now to fillings, probably one of the most common findings in the examination. Of course, in the examination paper, you just write down filling, but of course, for yourself, you should always think what kind of filling it is. Also, if you use the index DMFT, you should know if it's mesial, distal, occlusal, which class, according to Black, for example, which material, amalgam, glass ionomer, or composite, and also the state of the filling. Check the margins if they're like good sealed to the tooth. Check for fractures. Check if the filling is loose, maybe, or just the general condition of the filling, and if it may be necessary to renew it. Also check for secondary caries, obviously. Next slide. Yeah, here's some pictures of like bad things about fillings that you can find. In the X-ray picture and the bite ring, you can see a very common mistake is the overhang, like in the proximal box. It's hard to see in the mouth because it's usually like interproximal between the teeth, but you can always see it in the bite ring. And sometimes you can even see it in the mouth if it's really obvious or if there's some spacing between the teeth. And you can see in the red circle that usually leads to accumulation of plaque and bacteria, and in the end to secondary caries. In the upper left one, you can see a fractured filling. So what you do, you take out the old filling and make a new one. Yeah, you see really bad marginal adaptation on the upper right picture, and probably also developing secondary caries. Same on the lower one, you don't see it really well, but on the black arrow where it points, there's some secondary caries in the proximal box. Next picture. Okay, so caries. To check the teeth for caries, you have three methods basically to choose from. First is always a visual examination and also the palpation with the probe. Then there's the X-ray examination, and then there are additional methods like magnification, tooth separation, and fiber optic transillumination, and so on. I'm not going to go too deeply into those now. I'm just going to go over the normal visual examination that you do in the mouth, and later we'll also go about X-rays a little bit. First, some basic principles before I come to this. Like I said before, but for caries, it's especially important to have a dry field. You always should dry the tooth with air. That makes it much easier to see the caries, and you should use your probe, to palpate it. And yeah, basically caries can be in different regions, either coronal caries or proximal caries. Here it's like really obvious. Caries, it's brown, it's cavitated. But keep in mind that it's not always that obvious to see. Like caries can be brown, but it can also be white. It can be white spot lesions if it's an initial early caries lesion. If it's only in the animal, and it doesn't always have to be cavitated yet. It can be like an early lesion that didn't build a cavity yet. So pay close attention to this. And yeah, I mean, you're gonna have patients with your professor later, or already have. So just, better find more caries than there is and ask the professor, is this caries or is this just a decoloration, and like keep a look out for it. Next slide. Yeah, and then like what's often hard to see or maybe just confused with some white spots on the tooth is incipient caries, which is just first demineralization of the enamel. It's basically the start of a caries lesion. It's also called a white spot lesion, and it has like a white or chalky appearance. The probe may catch on it if you rub on it. It's not so totally smooth like the normal enamel. And it's usually like in areas where there's plaque and a lot of a lot of plaque and bad oral hygiene. So this could develop because of the bacteria. It is usually reversible if you tell the patient to improve its oral hygiene, and if you do some remineralization fluoridation processes in this area. So it's not really indication for restorative treatment yet, just for preventive treatment. But keep in mind that you can find those white spot lesions. And for those lesions, it's especially important to have a dry field, because those you usually don't see if the tooth is wet. Next slide. Yeah, and another form you can see, especially in, no, not maybe especially in older patients, but yeah, is the arrested form of the caries, which usually looks like you see here on the picture. It can be either arrested white spotted lesions in enamel, which have a shiny surface and maybe black in color, but also white. They are more resistant to acid than the sound enamel, and the consistency is hard. So it's not like soft, like decayed hard dental tissue. To the probe, it will feel very hard. And the arrested caries in dentine is usually brown and yellow and has like a leathery consistency due to the presence of tertiary and sclerotic dentine. This is what you see on the picture here, is the arrested caries in dentine. The arrested caries does not have to be restoratively treated because it is arrested. Like that means the oral hygiene of the patient has improved, the dental tissue got reminimalized, and the caries disease is not like further progressing. So all you do in this case is to, I mean, you still mark it down as caries in the examination paper, but you usually just observe and see if it changes anything after a while, if the oral hygiene of the patient improves or not. And yeah, then you can still do restorative treatment. Next slide. Also, especially as in your first patients and as a third year student, second year student, it's very easy to confuse stains with caries. Stains can look very similar to caries, but they're not sticky, they're hard. They're basically just stained enamel, stained hard dental tissue. It's not decayed. So if you probe it, you will feel no difference to the, while in caries, it's always softer tissue, and you can even feel often the cavitation if it's cavitating caries. And it's usually caused by food intake, for example, regular coffee drinking. Next slide. Yeah, here's some like examples from stains. One back here. From smoking, wine, from food, age yellowing. Teeth usually get more yellow during the higher age. And also here it only says shows from the lingual surfaces, but obviously you have a lot of discoloration in the fissures of the molars, which can easily be confused with caries. So just use your probe, don't only use your eyes, and you'll usually see the difference or feel the difference. Yeah, I said what white spots lesions are, that it's usually the early caries lesion. However, it's not always early caries. It's also a common cause is dental fluorosis, which is occurs when you consume too much fluoride. This is typically happening in children before the teeth break through the surface of the gum. Down here we have again mentioned the optimal fluoride intake. Always know this number. Kukletova in every exam, she she loves this number, and she loves everything with fluoride, especially in preventive dentistry exam. But yeah, this you'll have in your lectures too. So yeah, another thing you can find is a fractured tooth. There are a few different types of fracture. You will learn about this in oral surgery later, especially. It can be horizontally or vertically fractured. That's like the most common distinguishing feature of the fractures. Also, there can be also like coronal fracture, or the fracture can go into the root. Depending on what kind of fracture it is, you have to decide for the treatment plan. If it's just a coronal fracture, you can usually restoratively treat the tooth or make a root canal inlay or something like that. If it's a vertical fracture all the way down to the root, then usually it's indicated for extraction. And down here you also have something you all did in preclinical and maybe even on patients. It's just a number, class number 5 according to Black. So yeah, that's also just a fracture. Not 5, 4, sorry. Yeah, so periodontal examination. I'm not going to go too deep into this because I think last webinar was actually about indexes and stuff like this from periodontology. Just always in the patient examination paper, there's also a little column for oral hygiene where you just very briefly explain how good the oral hygiene of the patient is. So you just look for calculus, you look for plaque, especially interdental. Just because you don't see plaque first look doesn't mean there is no plaque. So always like go in a little bit interdentally with the probe. Look for gingivitis, look for gingival recession, and make yourself a picture on the like general oral hygiene of the patient. And if it's bad, then educate the patient that they should brush their teeth better, and maybe even show them how to properly brush the teeth or how to use floss or interdental brushes. But yeah, it's important to also write this down in the examination paper. And next slide. Yeah, and then there are all kinds of other things. I just wrote down like things that maybe a little bit more often happen, or at least it happened to me sometimes, is some impacted food that the patient comes with complaint of some pain or some pressure or something like this. And usually it's restored teeth, so it's not the natural contact point anymore, or maybe the contact point is not of the fillings is not good enough, and then food gets impacted there. So this you can find and remove. And also just movable teeth is if the teeth is like not anchored properly anymore in the alveolar socket. Next one. Yeah, I basically talked about this in the periodontal section. Just make yourself an overview over the oral hygiene. And then there's the examination. After you've done all the teeth, you examine the oral membrane mucous and generally all the soft tissues in the oral cavity. Here's a short list. I'm not going to go too much into detail because you have a really those of you who haven't had preventive yet, you will get it. And if you have preventive right now, I'm not sure if you had this lecture yet or not, but you can all find the lecture in the DENSOC Study Hub into second year under preventive dentistry. It's a very good lecture from Dr. Poshkorova about the soft examination of the soft tissues, and there she tells you all the things with nice pictures what you can find. So I'm just going to refer you to this lecture. All right, so if there are no questions so far for the clinical examination, the visual examination, we're going to go over a few X-ray study cases. I'm not going to go too much into theory of X-rays because we already had a webinar, I think, last semester or 2 semesters ago. So you can find this one on the DENSOC Study Hub if you want to have a look at this. Today, we're just going to go over a few cases and go over them together and see what we can find on them. Just very briefly, how to read an X-ray if they show you one, either in the practice or in the exam. First thing you do always is you don't jump directly in and say there's caries. You always first say what type of an X-ray projection it is. You say if it's an extraoral or an intraoral X-ray. Extraoral is most commonly OPG. Of course, there are others too, but at least in practice, I have never had other extraoral X-ray picture than OPG, and same in the exam. It's very unlikely that you will get anything else. Intraoral X-rays, however, you can get bite rings, periapical, occlusal X-rays, so you should know the differences in those. In case of the intraoral X-ray, say which side of the body it is, which teeth you can see, which structures you can see. Use the proper terminology, of course. Don't say dark areas and white areas. Say radiolucent and radioopaque. Be aware of cervical burnout. I put this as an extra point because I often diagnose caries where there was no caries in the beginning. Because if you look at this picture, it's you see the cervical burnout really well at the cervical areas of the lower teeth. You see kind of a radiolucent, dark shadow overlapping directly over the edge of the alveolar bone. And it looks a bit like caries because, it's radiolucent area in the dentine. But if you see that it's on all the lower teeth in the same way, then it's just this effect from the X-ray imaging technique that's called cervical burnout. So always be aware of this, not to say there's caries when there is none. Next slide. Yeah, in case of an OPG, always start with what kind of notation it is, permanent or temporary, and if there is temporary notation, then say how old the child probably is, according to which teeth are erupted and which are not. Then you can talk a little bit about the general picture about alveolar bone, if there's any bone resorption, either horizontal or vertical, if there's lamina dura present. You can approximate, like say something about the oral hygiene. I would always say, if you say this in the exam, I would always say that you can't obviously properly see the state of the oral hygiene on the X-ray. You can only estimate it according to level of bone resorption, level of the gingiva. On some X-rays, you can sometimes see how high the gingiva is. Presence of calculus. Calculus you usually can see on X-ray. Number of missing teeth, number of restored teeth. So this gives you like an approximate overview over the oral hygiene. But of course, you have to take a closer look in the mouth in clinical examination. Then really go tooth by tooth, like you do in the examination too, starting with 1/8 and describe everything about the tooth. It's very tempting just to look at the crowns, see there's no caries or no filling, then go to the next tooth, but always have a look at the radix and at the periapical area, because there might be like a periapical cyst or some bad endo treatment or something like this. And if you fail to mention this, that's not gonna go good for you in the exam. Okay, next slide. Okay, so we're just gonna go over a few cases now. I'm just gonna give you a minute to have a look at it, and then I'm gonna tell you what I find there or what's to see there, and you can see if you found everything relevant. Just keep in mind I'm a student too, so when I go over it and tell you what's there and I missed something, just raise your hand or something and let me know and tell me what else you found or might have found. Okay, I'm just gonna wait 1 minute. All right, I'm just gonna start going over it tooth by tooth now. So you really have to mention everything if you go over an X-ray. So always mention something that seems obvious to you. Like here, for example, number 8 is non-erupted in the upper right jaw. So say that, and yeah, and then continue tooth by tooth. So number 8 non-erupted, 7 is nothing. Number 6, we have MO class 2 filling. Number 5, it's endo treatment, and it's hard to see because some composite material is sometimes not very good visible in the X-ray. Depends a little bit on the type of composite material. So either there is simply no restoration of the crown yet, or maybe it's still gonna be, or maybe it broke, or there is actually one and it's just not visible on the X-ray. Yeah, but generally, if you see endo-treated teeth, you always should mention the state of the endo treatment. In this case, it looks good. It's homogeneous. You should always look if it's homogeneous or not, if it goes all the way to the apex, if all the roots, at least the ones that are visible, are treated. So here, everything you can see on this X-ray at least are good for this. Yeah, but you can't always see everything, just what is visible on the OPG. Otherwise, you would have to take a periapical projection of this area if you suspect some problem. Then number 4 is OD. Oh, hang on. Yeah, exactly. So it's also composite filling, like occlusally and distally, maybe a little bit mesially too. Number 3 could be like distally glass ionomer or composite. It's also sometimes hard to distinguish. I would say it's glass ionomer mesially and distally. Same in number 2 distally, but mesially you have composite filling. The two incisors are facet crowns, like metalloceramic crowns. You can see the metal cap really clearly, and on top of it you can either see ceramic or resin, but it's probably ceramic. Then in the second quadrant, the next thing to see is, or the next thing I see is on number 5, distally, you have some caries. It's quite clearly visible. You have the little bit conical radiolucency in the animal, and then the radiolucency underneath in the dentine. Same on number 6, you can see how the number 7 is leaning against the number 6 and probably causing some troubles there. And causing maybe some food impaction there and some plaque accumulation, and that's why there's a caries developing. Then in the third quadrant, we see a composite MOD filling on the number 7. On number 6, we see it is endo-treated. Again, it looks like a good endo-treatment, like both canals are filled, they all go to the apex, they're homogeneous. So if there are no problem, there's no need to suspect that there's anything wrong. Then number 5, composite filling and secondary caries mesially. If you can see this, there's some radiolucency under it. Then number 4, again a composite filling, maybe some secondary caries, but it's hard to see. With caries in OPG, it's always a bit tricky. Like sometimes it's very clearly visible, sometimes it's not, but it's always good to say if you suspect it, that you say we should do a bite ring in this situation to get a closer look. Or maybe look clinically in the mouth if it's occlusal caries, for example. Then in the fourth quadrant, like with the incisors, it seems all fine. In the fourth quadrant, the number 5 is root canal treatment and root canal inlay. Here, the root canal, the endodontical treatment looks a bit poor. You see under the tip of the inlay, like the canal is not really filled. There's some filling material, but it's only part of the way, and it doesn't go all the way down to the apex, and also not all the way up to the root canal inlay. But so far, there's no periapical lesion, no visible one at least, and if there's no inflammation present or anything, there's also nothing, like maybe no reason to renew this. Number 6, composite filling, number 7, composite filling, and number 8, it looks a bit brighter, so probably an amalgam filling. So if anyone found anything I missed, then raise your hand. If not, we go to the next X-ray. All right, then let's continue. Okay, so I'll give you a minute again and then come back to you. All right. So what I forgot, so good example, what not to forget, last X-ray is, of course, saying in the beginning that it's an OPG, say something about the bone loss. Here, for example, we can like examine both degrees of bone loss. There's horizontal ones like among the incisors, but you see where the extracted teeth are in the second quadrant, for example, you also see vertical bone loss. So I always mention that. But anyways, like for the purpose of this practice now of this seminar, I'm not gonna start with this every time. I'm gonna start immediately with what's to see on the teeth. So again, first quadrant, number 8, you only see the radix is still in the jaw. The crown is already decayed probably or fractured, broken. Number 7 is fine. Number 6 is extracted. Number 5 is endo treatment with the crown and root canal inlay. And you can see in the apical region there's like broadened periodontal space, so there's probably some periapical lesion or cyst, so probably some inflammation going on. So this has to be taken care of. Number 5, you only have the radix left from the tooth. You can see it used to be endodontically treated. You can still see the 2 root canal are filled all the way to the apex. So this should be either made into root canal inlay or extracted, but there's no inflammation around the apex, so it's not too bad. Here you can see number 3, number 2, number 1. They're like, or basically all the way to the nether quadrant, like they're all completely decayed by caries, like almost the complete crown is gone. Number 1, you can also see that it's endodontically treated. The treatment looks okay, but you can see there's just caries everywhere. Then number 5 is extracted, number 4. Number 5, again, root canal inlay, and about this white stuff at the apex, I'm not sure what it is. Maybe it's been overfilled in the endo treatment. Maybe it's something different. I guess you would have to maybe take a periapical projection from this area to see properly what it is. And then again, in number 6 and 7, you have the amalgam fillings, and also you can see the secondary caries. You can see the radiolucency under the margin of the filling. Then in the lower jaw, everything is extracted till number 5, which is endo treated. It looks okay, the endo treatment. It doesn't go completely to the apex, but there's no inflammation in the area. Also, it has some caries, mesially and distally. Same with number 4, distally has caries. The incisors, there's some radiolucency in the incisal like part. It could be that there's some filling, radiopacity, I mean. Maybe it's been like a composite filling, but it's hard to see on an OPG usually. This you would have to like check clinically in the mouth. Number 4 is a composite, could be with some caries, but it's hard to see on the OPG. And then the 5 is extracted again, 6 and 7 is amalgam, and again you can see like huge caries lesions. That would be caries pulpae proxima, like close to the pulp, or actually on 7 it actually already reaches the pulp. So always like mention that too. And 8 again, non-erupted or extracted. Non-erupted or extracted. Okay, if I missed anything, then write in the chat or raise your hand, and we can go next to the next X-ray. All right, again, I'll give you half a minute or 1 minute or so, and then I'll go over it. All right, so in this one, you can see huge amount of bone resorption. So you can probably also say that the patient has quite a bad oral hygiene. You can see both horizontal and vertical bone resorption. You can see that one 6 is like barely in the alveolar process anymore. And on 3, 6, you can see really nicely, mesially, like the vertical bone resorption, how it goes like straight down. Yeah, so this you definitely have to mention if you get a picture like this in the exam. Actually, I wanted to... Yeah, Julie, if you could go back to the first OPG one real quick. I forget to mention something there. Yeah, exactly. If you look at 1.6, you can see calculus. If you see those like little triangles on the like mesial side, this is how calculus looks in the X-ray. So they might also ask you, like on 2.7 or 2.8, you see it too. Like, yeah, so if they might ask you in the exam, what is this? And then you should know that it's calculus. Okay, we can go back to the other one. Yeah, perfect. Okay, yeah, so we can start here with number 6, which is a composite filling MO. Then number 5 is endodontically treated. It doesn't really look homogeneous if you look at the, like there's kind of a edge, like 90-degree angle in the middle of the filling. So there's no inflammation or no periapical lesion or anything, but it's also not a perfect endo treatment. Then 5, 4, and 3 are connected by a bridge. Bridge looks fine. Maybe 3 has some secondary caries, some radiolucency. But if you look at it, the radiolucency goes directly to where the line of the gingiva is directly next to it. So it might just be the overlap of tissues that it's not actually caries. So I don't think it's caries. Yeah, then you have the extracted 2, and then from 1 till 2, 4, 2, 3, you have the bridge. Metal or ceramic bridge, you should mention. You see the metal caps and the ceramic on top. 4 looks fine. 5 is a crown, metal crown, full metal crown. 6 is MO composite, amalgam filling, and 7 is occlusal amalgam filling. Number 8 till 4 is a bridge again. Number 8, you can see that it's a little bit overhanging, at least it looks like it distally. So that could cause some troubles with secondary caries in the future. Number 7 is endodontically treatment, looks all good, 2 canals filled. Or actually 3, you can even see the third mesial canal like slightly behind the other one. And yeah, in number 3, you can see huge distal caries, like you see properly the radiolucency there. And in number 4, like in the 4th quadrant, hard to say if it's caries or not, because the line of the gingiva you can see next to it, it also kind of goes in this area. So might again just be like that the overlapping tissue creates like a brighter contrast in comparison to the rest of the tooth. So you would maybe have to do some bite wing there or do clinical examination. Okay, so let's go to the next X-ray if no one has anything I missed. All right, this one, now we have the smaller ones, the bite wings, so I'm just gonna give you a few seconds to have a look on it, and then I'm gonna go over it. All right, so different kind of X-ray now. So you definitely should mention that it's a bite wing. I mean, it's quite obvious to see. You see even the like line in the middle where the patient was biting on. You see that usually that it only shows the posterior teeth and that it's the only coronal part and kind of in a 90-degree angle. So that speaks for bite wing, which is usually the X-ray examination of choice if it comes to interproximal caries, which we can clearly see here. First of all, you need to say that's the right side of the mouth, so it's first and fourth quadrant. And you see there's caries on 1.7 mesally, on 1.6 distally, on 1.6 mesally again, and on 1.5 you can even see a quite big lesion which goes into the dentin. You can see the animal lucency goes all the way through the animal and into the dentin. With all the rest of the teeth, it's a bit hard to say, especially in the lower quadrant, as they're overlapping. So either you should probably take another bite wing from a slightly different angle, so they're not overlapping. That's not usually the case, though. It should be in a bite wing that you can see your upper and lower quadrant properly. But in this case, the lower jaw teeth, they were slightly overlapping in this angle of the X-ray, so you can't really say if there's caries, but it doesn't look like it. Maybe between 4.6 and 4.5, there's some shadows there. Pardon me, radiolucencies. But yeah, you would probably have to take another X-ray for this. Okay, if there are no questions to this one, then we can continue to the next. Yeah, so same story, right wing of the first and posterior teeth of the first and fourth quadrant. And there's one lesion in this, it's really hard to see it. I basically just put this picture in to demonstrate how subtle it can be sometimes, especially if the X-ray quality is not great like this one. It's kind of blurry, everything. And you can see on 4.5 distally, you can see like a little conical. Yeah. All good, or any questions? I didn't hear that.
No, it's all right. Sorry.
Okay. Yeah, just on 4.5, you can see a little conical shape of the caries lesion in the animal, interproximal between the teeth. So yeah, really keep your eye out for those. Sometimes they're really hard to see. Okay, next X-ray. All right, so this is a bite wing from a little bit broader perspective. We can see more teeth here. It's again on the right side. Yeah, I'll give you a few seconds to look over it, and then I'm gonna speak about what's to find. Yeah, okay. So again, I think there's only one caries lesion, at least one good visible one, which is on 1.6 mesally. You can see the radiolucency even in the dentin. And yeah, what else to say is you can see really nicely the bone here. You can see that there is some bone resorption. It's not much. It's still on the level of okay, what I would say. But you can see that the lamina dura is already a little bit compromised. And it's a bit hard to see. I'm not sure if it's actually a filling, but it looks like there's a small amalgam filling occlusally on 1.6. All right, next X-ray. All right, I'll give you a few seconds and then All right, so now you would have to mention that it's a bite wing again, but also that it's on the left side this time. So you see the second and third quadrant. What's definitely to mention is that there's a lot of bone loss. You can see horizontal bone loss like basically everywhere. And if you look at 3-6 and between the roots of the tooth, you can see like some area of inflammation, some kind of cyst. There's some radiolucency going on there. So there's definitely some inflammation. And also maybe on 2-5, mesally you can see some like very early carious lesion, but this is hard to see. That definitely doesn't indicate restorative treatment yet. It's maybe just to monitor. Like it's just a really small lesion just starting. But definitely you should tell the patient and like educate them on oral hygiene and how to clean the interdental space there. Okay, to the next one. All right, so here you should now mention that it's a different type of projection again. Happened to me in exam once that I saw this and immediately thought bite wing, and of course that was wrong because it's a periapical projection. If you see the whole tooth like you do here, it's periapical. And usually I also just see one jaw, not both jaws like you do in the bite wing. This projection is usually used if you, like the name says, if you need to see the whole tooth until the apex, if there are some endodontical problems or periodontical problems. In this case, you can see on 4-4 you have a periapical cyst, periapical lesion. It's quite a lot of bone resorption there. And of course, like a lot of caries on 4-4. The whole crown is destroyed by caries. And 4-6 and 4-5, you can see metalloceramic crowns. Or probably metalloceramic, could be resin, but definitely facet crowns. Just say facet crowns in the exam. Like that's more safe than saying metalloceramic. Okay, if I didn't miss anything, then we can go to the next one. Yes, a little bit more on the picture, so I'll give you a few seconds again. All right, so this is a bite wing again of the right side. Here again, you can see the cervical burnout pretty well, especially lower quadrant on the right by, what is it, 4-4 and 4-3. You can see the cervical burnout quite clearly. It's not caries. It's just this effect that's like tricking you a little bit. Then you should definitely mention that 1-6 is extracted and that 1-7 and also 4-6 are like migrating into this gap. You can see 1-7 is leaning into there quite quick. Not 1-6, sorry. 1-6 and 4-7 are migrating in there, and 4-7 is already tilting into the gap from the extraction quite a lot. So there you definitely need some prosthetic treatment to keep the tooth from drifting into there. Also, there's quite a lot of caries going on here. Not all of them are super big lesions, but on 1-4 distally and on 1-5 mesally, you can see some like small lesions in some small radiolucencies in the enamel. On 4-4 distally, you can see quite a big one. Oh, is it? Hang on. 4-4. No, pardon. Sorry. So 4-4 distally and 4-5 mesally, you can again see small ones, like they're just barely scratching the surface of the animal. At 1-5, however, distally, you can see a very big lesion, like it goes all the way into the dentin and almost halfway through the pulp already. And also 1-6 distally, you can see lesion that goes already into the dentine. Not as much as in 1.5, but it already reached the dentine, so it's not only in the animal. Okay, next one. Only 2 more, guys, and then we have it. Okay, one moment. Yeah, there's not much to see here, so I'm just gonna go ahead and say it. So it's a periapical projection again. Always mention that. I'm not 100% sure. I think it's 1.5, and it's endodontically treated. It has a root canal inlay with facet crown on top. You see secondary caries distally, definitely under the inlay. And also you can see 1.4, the crown is completely destroyed by decay, and it also has been endodontically treated. So yeah, that's basically all there is to say to this X-ray. And then to the last one. Yeah, I can give you a few seconds again, and then I'm gonna tell you what's to see here. All right, so another periapical projection. Good example for a case where it's not enough just to say it's endodontically treated. You have to tell the teacher, or even in practice, you should have to know for yourself and for your treatment plan how it is endodontically treated. And in this case, it's not very good. You can see it's not homogeneous. There's like radiolucencies in the root canal filling. Also, the root canal filling doesn't go all the way to the apex, and you can see on both apexes it's already causing problems. You see the periapical lesions on both of them, so you definitely have to redo this in endo. And worst case, the tooth has to be extracted if the inflammation can't get under control. Also, you can see the crowns in 4.7, especially. You can see that the margin of the crown seems to be overhanging a bit, so that also should be fixed. If it's actually if it's just the angle that it makes look like this, but you should definitely check it in the mouth. And if it's an overhang, then you should try to fix it and renew the crown. And yeah, the crowns are facet crowns again, probably metalloceramic. And yeah, I think that was the last X-ray. Let's see if there's another one, but no, that was the last one. So yeah, thanks everyone for showing up, and I hope it wasn't too long, and I hope I could give you some nice information about clinical examination that you can make use of in your next patient. And this will be uploaded on YouTube if you want to have a look at it again and want to go over the X-rays. And generally X-rays I can just recommend in practice whenever you have time between patients. Just go over X-rays. Ask your professor, ask the teacher if they can go over some X-rays with you, and just practice. And that's really the best thing you can do. Also in the Dentox Study Hub, and probably also your teachers gave it to you already on IS. There's a big document about X-ray reading from, I think Dr. Batakova created this. And it's really well explained, and there are also a few case studies in there that you can have a look at. But yeah, for now, that's it for us. So thank you very much.
Thank you.
Thank you, Moritz. Bye-bye.
Thank you.
Bye.